Just wait a few more seconds for more people to join and we'll start. Good afternoon, good morning, good evening. Welcome to all of you, especially those of you who've joined from places that are very late at night or early in the morning. Welcome once again to today's WHO EPI-WIN webinar. Our topic today is growing threat of Crimean-Congo Haemorrhagic Fever and control strategies through a One Health approach. We have, as always, a very exciting panel of experts to talk to you about this viral fever. We have Dr. Maria van Kerkhoff, Director of EPM, to give the welcome remarks. Then Anna Legend, who's the viral hemorrhagic fever expert here at WHO headquarters, will give you a general overview. And Kiori Kodama, medical officer in WHO Eastern Mediterranean region, will give an overview of CCHF in that region. But after that is the most interesting part, because we will have Dr. Adnan Kamasi, talk to you about the actual efforts in Iran in practice in the country. Of course, as always, we welcome your questions. So the normal announcements. This is being recorded. We would love to hear from you, so please introduce yourself in chat and share your experiences and comments on the chat. But if you do have a question, please put it in the Q&A box. As you know, that's where our experts will see your questions and be able to respond to you. Please keep all your comments respectful and relevant to this topic. Anyone who is disruptive or disrespectful will be taken off the webinar, but I hope we will have a very constructive, positive discussion on this forum. And of course, to all of you who celebrate Eid Mubarak, and we'd love to hear from you as usual. So first of all, before we start off the session, I'd like you to answer our Slido. So please go to slido.com #3699202. That's slido.com #3699202. And tell us, what are the first words that come to your mind when the words Crimean-Congo Haemorrhagic Fever is mentioned? Very quickly. That's interesting. Cattle, ticks, bleeding, public health emergency. So that's wonderful. I will now stop sharing this on the screen, but this will be open. So please continue to go to slido.com #3699202 and put your feedback in. It's really nice for us to know what you think about this. But without further ado, I will hand over the floor to Dr. Maria van Kerkhoff, who, of course, needs no introduction in the public health world. Over to you.
Good morning, Supriya. Good morning, good afternoon, everyone. Thanks very much, and welcome to this EPI-WIN webinar on Crimean-Congo Haemorrhagic Fever, or CCHF, as we call it. So it seems like many of you already very well know that CCHF is a tick-borne severe illness in humans. And in humans that have been reported from a number of countries on the African, the European, and the Asian continents. Because some tick species are the viral reservoir and transmission to human mostly occurs through a tick animal cycle. Sorry, I'm a little bit under the weather, so reading is difficult for me at the moment. Because some tick species are the viral vector and transmission to human mostly occurs through tick animal cycle, factors impacting tick distribution and density, animal movement, and human interaction with ticks, wild and domestic animals may impact the distribution of the disease. The disease was first reported in 1945 in the Crimean Peninsula. The virus causing the disease was first isolated in 1967, both in a blood specimen from a patient from the Democratic Republic of the Congo and in a blood specimen from a patient from Crimea. Interestingly, the virus was recovered from human remains from an archaeological site dating back 600 to 450 BC during the Iron Age in what is now Germany. This suggests that the virus has been around for centuries. More recently, since 2010, additional countries have been reporting CCHF in humans, with an instance in Portugal confirming its first case last year. Today, we're going to focus on the Eastern Mediterranean region, one of the most endemic regions for CCHF, where regional efforts are ongoing to support prevention and control through a One Health approach. You will hear excellent presentations from speakers from WHO on CCHF, including a presentation about country-led interventions from Iraq, which has seen a high increase in the number of cases since 2022. The aim of today's webinar is to raise awareness and to encourage endemic countries to be ready for the upcoming season that will soon start. In particular, WHO is supporting member states to improve early detection and clinical care. All of the work that we do for CCHF is conducted with our partners to ensure strong collaborations with the animal sector, including tick control, using a One Health approach. Thanks very much for the opportunity to present all of you today. Thanks to my colleagues at HQ in the regions and in the countries for the great work that you do on this space. And back to you, Supriya.
Thank you very much, Maria, and I hope you feel better soon. Thank you for that introduction and welcome. Now to give an overview of CCHF, I invite Anai. Anai, over to you.
Apologies, I had issues to find the unmute button. Hi, everyone. So without delay, I'm going to give you a brief introduction to CCHF. You will receive the slides, so I won't go through all of them, but it's just to give you an overview of what we know to date and how we can protect ourselves. So moving on, as Maria mentioned, this is a disease that has been widely reported in many countries. With a global burden that is estimated to 10,000, 15,000 CCHF infection, keeping in mind that in most infection, the patient will not be sick or have very limited symptoms, but that gives us 20% of the cases approximately that will result in severe disease. And also the vector is widely distributed, putting therefore at risk 3 billion people globally. To start with transmission, and Maria alluded to it, but also I could see from the slide that you all well know the transmission, but just to recap, as we know, the main reservoir is mostly the Yellowma tick species, although we know that other ticks can also carry the virus. In which the virus can be maintained through a tick and vertebrate cycle, including wild and domestic animals, including livestock, but also birds. It's important to mention that most animals, especially the livestock, won't show symptoms, except for ostriches, for instance. So then how get human contaminated? So it's mostly through tick bites or direct contact with blood of an infected tick, and or through direct contact with blood or tissues of infected wild animals and livestock. That's the primary route of transmission, and we see that 80 to 90% of the human cases result from one of these routes. We know that secondary human-to-human transmission can occur through direct contact with blood secretion or body fluid of an infected patient. And of course, this risk is higher for people providing care. Briefly, the disease incubation period is from 14 days, The case fatality ratio may be quite high, up to 30% and above, and it depends on a number of factors that could include the genotype type of the virus, but also obviously access to care. The symptoms are at the beginning very not specific, like a typical viral symptoms with malaise, fever, and fatigue, and then we can see some bleeding on the severe cases. And that's why, because the symptoms are really not specific, it's very difficult to clinically diagnose the disease, and why we need patient history, looking at history of tick contact, contact with animals, but also contact with other CCHF cases. The recommended method for confirmation is RT-PCR for acute cases, but also IgM and IgG. The clinical care for the time being, there is no approved therapeutics or vaccines. We know there are candidate vaccines and candidate treatments that are being developed, but we've seen from many countries that the improved intensive care can reduce the case fatality ratio. WHO is supporting country to put in place some framework, especially in CCHF endemic settings, to look at preparedness, alert, control, and evaluation. And as we said, there is some level of seasonality, and this will be discussed by my colleagues from Cairo and Iraq. What you can do, and it's for CCHF, but also all tick-borne diseases, is of course engage with community to provide targeted prevention measures that specific group can implement, especially the ones that are at risk of exposure to ticks, exposure to livestock, and of course, healthcare worker. For the tick-to-human transmission, the protection from tick bites, ensuring that people do daily tick check when it's feasible and how to safely remove a tick from a person are good messages, of course. On the limitation of the transmission from the animal settings, there are some work that can be done to reduce the ticks in the livestock environment, but again, not an easy work to do, especially with resistance to acaricide and the impact it can have on the environment. There are also ways of quarantining animal prior to slaughter to decrease the risk, but also to protect people that are involved in slaughtering, formal or informal, in many settings. In terms of human-to-human transmission, again, early detection leads to improved supportive care and probably to decrease the case fatality ratio. But most importantly, it will also decrease time in community, reducing the risk of transmission, and in healthcare setting, as for many other blood-borne disease, IPC needs infection prevention and control measures should need to be fostered. To conclude the perspective, again, we need a good understanding of CCHF ecology so that targeted action can be done in most at-risk countries. We need to strengthen the One Health strategy, especially at field level and globally looking at additional products and innovation, including diagnostic therapeutics and animal vaccines. And I will stop there. Any question, feel free to send, and you will receive the slide. Over to you, Supriya.
Thank you very much, Anai, and to all participants, please put your questions in the Q&A, and all our experts will do their best to address them. Thank you so much for that very succinct and nice presentation. We will now hear about specifically CCHF in the Eastern Mediterranean region from Kiora Kodama. Over to you, Kiora.
Thank you, Supriya. Hello, everyone. Good morning, good afternoon, and good evening to everyone across the globe. This is Kiora Kodama from WHO EMLO, the Eastern Mediterranean Regional Office, where it covers 22 countries across the Middle East and also northern part of Africa. Thank you very much again for this great opportunity to present on CCHF, Crimean-Congo Haemorrhagic Fever, which is one of the high-threat pathogens and also viral hemorrhagic fever with high mortality that continues to be a major public health threat in our region. So as my colleagues, Maria and Anais from headquarters, just to describe the overview of CCHF, this simple infographic you are seeing on the screen represents how CCHF is usually transmitted to humans. So usually through tick bite or direct contact with blood of infected ticks, or direct contact with blood and tissues of infected wild animals and livestock, and also their human-to-human transmission, such as nosocomial infection or household infection. So this is a geographical distribution of CCHF affected areas and regions. As you can see that our region plays epicenter when it comes to disease transmission and also the spreading across borders and regions. So in history, our region has reported human cases and outbreaks of CCHF from 9 countries listed here. In some countries, the incidence of CCHF has been increasingly steadily in recent years, particularly in Iraq, Afghanistan, Pakistan, and also Iran. However, there are many difficulties remain in controlling CCHF. In addition to limited resources, there are many knowledge gaps, no approved therapeutics or vaccines available to date. So these data suggest that there is a clear seasonality in CCHF epidemics, which is usually between March, April to September. That is corresponding to the activity period of CCHF vector, Hyeloma ticks. And also the rising temperatures in recent years have increasingly favored the habitat and the reproductive cycles of ticks, which is also indicating an extended period of tick activity in recent years, thereby extending the period of transmission risk for CCHF virus to humans. And the increased personal slaughter activities during the holiday season, such as Eid al-Adha, is a potential and regionally unique driving factor for CCHF transmission as well. And also, there are many other responsible factors potentially affecting the CCHF epidemics. For instance, during COVID-19, tick and animal control activities have been suspended in many countries and settings due to the social restrictions, which may have contributed to the CCHF outbreaks in endemic settings. So when it comes to CCHF control, there are various challenges existing by context, including limited resources across human and veterinary sectors in control of CCHF, and limited social awareness among community in protection and prevention of CCHF, and the cross-border movement of humans and animals that continues to spread the disease. And the vulnerable populations in those endemic settings, there are many vulnerable populations existing and living in challenging conditions. They can be a source for disease transmission, but also at the same time, they have limited access to healthcare services. And those unprotected slaughter activities and also the close proximity between human and animals, and the limited understanding and application of CCHF control strategies, including animal and tick control, poor infection prevention and control adherence, and the inadequate management of patients, including nosocomial infection. For instance, in some settings, culturally, it is very common that the patient families are taking care of an admitted CCHF patient in the hospital. And the suboptimal surveillance, laboratory confirmation, and case management, which makes it even more difficult to understand the actual degree of CCHF morbidity and mortality in our region. And the limited operational research in both human and the veterinary sectors, including vaccines and treatment, tick study, and also acaricide resistance. And the limited One Health approach that is integrating human, animal, and environmental health strategies. So the government and the multi-sectoral commitment and the engagement are essential in controlling CCHF epidemics. So how can we operationalize One Health for the effective interventions in control of CCHF, and not just talking about the theoretical One Health concept? So there are many ongoing response actions taken in CCHF-affected countries in the region. While responding to outbreaks in control of CCHF, we are also trying to identify and confirm the evidence-based control strategy for CCHF through the One Health approach. For instance, enhanced surveillance in both human and animal sectors, and the widely distributing and training of CCHF standard case definition to all healthcare facilities, and the CCHF case management treatment algorithm was developed and provided trainings to a wide range of healthcare professionals, and the infection prevention and control training was also integrated into case management. And the clinical data collection and the observational study has been conducted on the collected patient data to identify the best the treatment protocol. And the quarterly tripartite, the meeting between WHO, FAO, MOH, and the Ministry of Agriculture, and the joint action plan was developed for the control and response to CCHF through One Health approach. And also the laboratory support, the procurement of laboratory supplies and trainings for CCHF diagnostics, such as the PCR, ELISA, and the sequencing for both human and animal labs, and the risk communication and the community engagement at the field level, and delivery of key message, for instance, how to protect yourself from tick bite and the safe slaughter practice, etc., through the social media and the national media outlets. So as I mentioned in the previous slide, there are so many unknowns and challenges still remain with CCHF control. In order to tackle these challenges and also to identify the best control strategy, we have been collecting and analyzing data with WHO country offices and national authorities, and this effort is actively progressing now. So one of the major achievements is Iraq. They had the biggest outbreak of CCHF in 2022 and 23. And with the strong commitment from the Iraqi government and WHO country office for Iraq, we have collected and analyzed the data and confirmed some scientific facts behind the outbreak in Iraq. So this infographic you are seeing in the center of the slide, this represents what has happened in terms of CCHF outbreak in the interface of human and animals and environmental health, as human large seasonal outbreaks were preceded by the increasing in tick population. Then CCHF virus was transmitted by ticks to domestic animals, and then to humans. CCHF epidemics correlate with the tick population, so effective and early tick control is a key to prevent and control the CCHF outbreaks. So which requires multidisciplinary One Health strategies, integrating human, animal, and the environmental health strategies. So now I give the floor to my colleague from WHO Country Office for Iraq, Dr. Adnan, to take us through the CCHF data and the experience in Iraq. Thank you very much. Dr. Adnan, you have to unmute.
We don't hear you. I think you're still muted.
Now, you
Yes,
hear me?
we can hear you
Good.
now.
Yeah, thank you very much. I will share you my presentations about the CCHF in Iraq. You see the slides, please?
Yes, we see your slide. Could you please put it in presentation mode?
Good, yes, good.
Yes.
I put it.
Thank you.
Actually, CCHF not known in Iraq until September 1979, when a female patient presented with general hemorrhagic symptoms and died on 9 September. 4 days later, a senior resident physician and an assistant both had direct contact with the first patient. Both died. During the same year, 10 CCHF cases were diagnosed, 8 female and 2 male, with case fatality rate 70%. The disease was reported from well-separated areas of the country, which suggests that the disease is endemic. The other 8 cases had direct or indirect contact with sheep or cattle. Ministry of Health immediately put all their facilities and manpower to elucidate the nature of this disease and its control. Quarantine measures were undertaken in some of Yarmouk Hospital sections where the first patient is admitted. Neighboring countries were notified. Help was requested from WHO. This is the trend of the CCHF cases since 1986. You see, till 2022, there is some cases yearly reported in Iraq. During 2022, there is a huge surge, followed by 2023. This is the trend of the disease. The surge of CCHF cases actually started at end of 2021. This surge can be explained by the impact of COVID-19 pandemic, which lead to cessation of control measures taken by Ministry of Agriculture, like dipping and spraying of the animal. Climate change. Iraq is one of the 5 countries in the world worst affected by climate change, according to the World Bank. Climate change lead to the internal population displacement that lead to increased population density and animal density, which made the disease transmitted easily. And here is the distribution of the cases. The most of cases are in the southern of Iraq, the Kar, Basra, Misan, Wasat, and Al-Muthanna. These provinces in the south of Iraq. And this is the map. You see, but the disease is a little bit growing for the north and the middle of Iraq. This is the seasonality, as Dr. Churi mentioned, that it started during March and the peak is during June, July, August, then return back during September and October. This is the weekly epidemiological curve, actually. During the last years, you see there is a spike or an increase in number, 20, 69, and 22. Actually, this increase in numbers, it is during the week of Eid al-Adha, when there is a slaughter of the animals inside the house, and a lot of animals slaughtered during Eid al-Adha. Here is the zero. Here is the actually the infested animals according as a percentage by ticks. You see, sheep 86, 71, 39, buffalo 35, which means that the animal in Iraq, it is already infected with the CCHF. Yes, we all of us know that the animal, there is no symptoms for appear on the animal, but this is an infestation of the ticks. Here is the zero survey done by the Ministry of Agriculture over all of the animals, the buffalo and cows affected, 37 all over the country, and you see that the southern provinces affected more. Here is the seropositivity among the sheep and cattle, 17% overall. This is the age and sex distribution of the cases. You see that the male affected more than female, and the most affected age group is the productive age group from 25 to 44. Here is the occupation. You see that 37% of the housewife affected with the CCHF. It doesn't mean that maybe it is due to their contacts with raw meat, or the female in Iraq, it's working in the farm and so on. So maybe due to that, due to the contact with animals and with the ticks. WHO actually, in coordination with the Ministry of Health, did a lot of activities regarding the surveillance, building capacity for rapid response team, outbreak investigation, strengthening surveillance, building capacity of laboratory for detection of the virus through provision of diagnostic kits, training, including the gene sequencing training for both the human and vet sectors. Advocate for multi-sectoral approach, One Health approach to control the disease, and One Health Committee was established. Regarding the case management, development of CCHF National Treatment Protocol with the procurement of essential medicine supplies to hospitals, raising awareness of the frontline health care professionals for early suspicion and diagnosis of the disease through dissemination of standard case definition for all health facilities, developed a CCHF case management algorithm, which was disseminated to all health facilities responsible for the care of CCHF cases. The trainings to improve case management capacities among healthcare professionals to reduce mortality. The other key areas is the RCCE targeted the risk group in the rural areas, the social influencers. 5-year strategic plan was drafted and submitted to the Ministry of Health and Ministry of Agriculture. And the Crimean-Congo Survivor Care Program started in Basra, DOH. Unfortunately, this program is stopped now because of the withdrawal of the USA fund. What is the achievement? Is the reduction of the case fatality rate. Now, during 2024, the case fatality rate is below 14%. Second achievement is the declining of the cases over a year. And this graph revealed that. The challenges, as Dr. Churi mentioned, limited workforce, particularly in Ministry of Agriculture and veterinary sector, and availability of sufficient proper slaughterhouses in the country, and controlled animal movement inside the country and on the border. The needs is the sero-survey studies and research on both sides, human and animal, are crucial to understand the epidemiology of the disease and its real prevalence. A study on the ecology of the tick vectors, effectiveness study of the acaricides on regular basis, global scale research for CCHF vaccine, both for animals and the human, applied research for effective antivirus for CCHF. These are the photos from the field missions done by WHO and Ministry of Health to the affected provinces, mainly the Qar. This is for the Qar, and this is one of the activities of the RCCE to the social influencers and to the in the rural areas, and a joint mission between Ministry of Health and WHO. And this is the meeting of the One Health Committee to discuss the control measures and the epidemiology of the disease and so on. These are the field visits of the headquarters and IMRO experts, Dr. Pierre, Dr. Churi, to the hospitals in the southern of Iraq. And here is the joint mission also between the Ministry of Health and WHO to for the control measures done by some of part of control measures done by the Ministry of Health and other parts done by the Ministry of Agriculture. Thank you.
Thank you very much, Dr. Adnan, for that very comprehensive presentation on all the work being done across different areas for CCHF in Iraq, and some very nice pictures of the field trip as well. So thank you for that. We do have quite a few questions now. And since that's the end of the technical presentations, we move over to questions. And happily, we have some time to answer questions as well. So let me start with I'm just looking through the questions. There's a very specific one from Sophia Appelberg. What strategies for surveillance for CCHF in animal populations are currently being used? Is it PCR on serum samples, ELISA? Does anyone want to take that?
The questions for me?
If you'd like. There is actually, we can come back to that question later. A specific one for you, Dr. Anand, from Mohammed Umlai. What would be the best way to stop the house slaughter to minimize the cases incidence of CCHF, especially during Eid al-Adha?
To me, the question?
Yes, that's for you. That's specific.
Actually, I think the availability of proper and scientific slaughterhouses in the state, it will prohibit or minimize the slaughtering inside the houses. But unfortunately, in Iraq, there is no proper and efficient and sufficient slaughterhouses in Iraq. So that even not in Eid al-Adha, so many slaughtering done outside the slaughterhouses, because there is no slaughterhouses, of course. So most people are slaughtered in the street, but during the Eid al-Adha, it increased. Yeah, thank you.
Thank you. And then also for you, there are a number of questions from Mustafa Salehi Vaziri. The first is, what is the CCHF virus infection in ticks in Iraq? So is there surveillance for ticks there? And the second question he has is CCHF virus genotypes circulating in Iraq. So there are two questions from the same person. One is the CCHF virus infection in ticks in Iraq, and the second is CCHF virus genotypes.
Asian type, actually. We did a gene sequencing for the viruses. It is the Asian type. Okay, but this is in a human. In ticks, actually, due to the unavailability of the PCR kits to diagnose the virus in the ticks, there is a limited studies and limited work done in this field. Yes, WHO trained people from Ministry of Agriculture for how they extract and how they deal with the ticks and extract that. But unfortunately, there is no kits to diagnose the virus in the tick. Okay.
Okay, thank you. The next question, I'm just randomly pulling questions out from the Q&A box here, is from Ayu Putu Madri Devi, and that question I will ask Anai first. Are there any early warning systems for detecting CHSF hotspots before outbreaks occur?
Yeah, this one is a bit tricky, and you'll see in the literature a number of, and someone put a very interesting paper that I would encourage reading to try and understand what are the places of emergence and the risk factor. And for some countries, it's well documented. We can think of Turkey, we can think of Iraq, of Iran, and others, of course. But the early warning in most of these countries that I mentioned, it's seasonal, starting, as Dr. Curie, Dr. Hanan mentioned, in April and up to September, more or less. Probably, and most likely, I would say this would be different depending on the ecology and the place we are talking about. In Africa, many countries report ticks throughout the years. It's very sporadic number of cases with 0 to 10 confirmed cases a year. But in terms of early warning system, so first, the countries that are endemic for this disease know when it can start and know most of the time what the highest places where is the highest risk. So that's how you should implement preparedness and alert action. But if you are asking me in a non-endemic setting, this would be a bit tricky because we, for the time being, don't understand enough the ecology everywhere. I hope I answered the question.
Thanks, and you have a very clear answer to a potentially tricky question. I will now go to a more technical one to Kiori. This is from Abdul Kader Ilbudu. I hope I've pronounced it right. The question is, seroprevalence studies in sub-Saharan Africa suggest that CCHF may be underestimated in this region. What strategies are currently in place to strengthen surveillance and assess the true burden of the disease?
Yes, thank you very much for this important and also very complex question. So as my colleague Anais just described, this early warning system for surveillance, it's also depending on the country's the adapted surveillance strategy. For instance, in our region, that many countries has adopted EPI-WIN or EWARS strategy, that and also many countries are also shifting to IDSR, Integrated Disease Surveillance and Response System. So if the country is already endemic, that the CCHF, the case definition and the surveillance system must be already integrated into the national surveillance system. But however, your country is still not ready or not experiencing the large number of CCHF cases among humans, that but as I described earlier, even in our context, besides, apart from the human endemic countries, there are many countries that from our seroprevalence study among animals is indicating that it is more that we are underestimating the actual disease burden. So if you are asking that what kind of integrated surveillance strategy is implemented here, then it's also that that is the most challenging area, because that requires always the veterinary sectors and also the Ministry of Agriculture's commitment and also the sustainable resources, because the conducting with the huge appreciation to Iraqi government, they have conducted, Ministry of Agriculture, they have conducted this, the animal seroprevalence study among domestic animals. That is, the strategy they used is ELISA, but even doing so, that because it's very hard to repeat this animal surveillance, because it's usually compared to human sector, the animal sectors, their resources very, very limited. So first, through this One Health approach, we have to we have to ensure the sustainable resources to understand more the CCHF prevalence among domestic animals, and also the more tick study needs to be done. And then the human study also has to be continued. So how we can institutionalize this One Health approach across human and animal and the environmental sectors, that I don't have the straight answer to give you, but we have to really work on more advocacy and also more continuous fundraising to secure and to ensure this One Health approach. Thank you. Back to you, Supriya.
Thank you, Kiori. I think this is a related question, since you're talking about, challenges of One Health approach. This question is from Voldekiro Sego, And they're asking, with the rising threat of CCHF, what are the biggest challenges in successfully implementing a One Health approach to curb its spread? Also, how can we strengthen collaboration between human, animal, and environmental health sectors to enhance surveillance and improve response efforts? You touched on this a little bit in your previous answers. So is there anything more you'd like to say to this participant's question?
Yes, so the biggest challenge when it comes to operationalizing a One Health approach, I guess that is the question, right?
Yeah, yeah.
So there are many the biggest challenges when it comes to operationalizing One Health, but I would say that the first the ministerial the cross-ministerial collaboration, because the sharing of the timely data between the line ministries, particularly between Ministry of Agriculture and Animals, and then with Ministry of Health, that is supposed to be responsible for human sector. And also, particularly when it comes to CCHF, it is usually asymptomatic. It doesn't really do anything to animals. So, like, investing a lot of resources into those animal surveillance and also the tick control, that is not really going to be the timely benefit for the veterinary sectors. And also that when it comes to meat industry, that is also the conflict of interest between human and animal sectors. So how we can break through this conflict of interest, and then how we can deliver more timely the data sharing, information sharing, and then align with the same strategy, and then implement those actions. So for instance, we need to identify the most effective acaricide, and also the acaricide resistance, that in each context, which is basically the which should serve as a golden strategy for tick control. But we have to also fund them. We have to give them the sustainable resources to continue this tick study and tick control. But who is going to be the funding source? It is really the big scale question and the big scale answer. And that's why today we requested to host this meeting.
To create more awareness of the issues. Thank you very much, Kiori, for spelling this out quite nicely. There's another question which is interesting. Is there this concern about cross-border? So is there any cross-border disease control protocol for animal surveillance? Who would like to take that? Kiori, you again, or Anai?
So as a regional office, we have been always encouraging our member states to put such a cross-border the animal control strategy in prevention, not only for CCHF, but also other high-threat pathogens, and also other zoonotic diseases. But however, again, really sharing the same strategy and sharing the same priority, and also breaking through this conflict of interest between animal and the human sector, it's always the biggest challenge for us.
Thank you.
Yeah.
Then I have two questions about managing the situation. The first one is, what are the infection prevention control measures to be taken, particularly for animal, for One Health and animal, but also overall?
So what when it comes to IPC measures applied to animal is the major one is basically the protected slaughter activities. For instance, as Dr. Adnan kindly described earlier, that there are so many unprotected slaughter activities ongoing in not only in Iraq but also in the region, and also it is during the Eid al-Adha. There are many home slaughter activities, and it's usually we we suppose we are also suspecting that it is also linked to the increasing number of CCHF human cases. So, when it comes to those the IPC measures put around the animal health is the major IPC measures, and also we are always constantly delivering this message to animal owners and also those the people who are engaging in veterinary health. That, for instance, those vets and also the animal owners, that they have to be protecting themselves. And also when it comes to the human healthcare settings, we are constantly delivering this the human IPC measures. And also, as I mentioned earlier, in our region, it is very common, particularly in the context like Afghanistan, it is very common that the patient families are taking care of the CCHF patient in the hospital. So we are constantly delivering this message through the different media outlets. Thank you.
Thank you, Kiori. Dr. Adnan, can I ask you the same question in terms of Iraq? What were the IPC measures that were taken in Iraq?
Yeah, actually, the IPC measures depends on the mode of transmission of the disease. For example, what we request or what we advised for the farmer or those with animal owner to take care from the tick, for example, exposure. They should wear an long clothes, special clothes. They observe their animals about if there is any ticks. So they will consult the vet physician and so on. The second point regarding the slaughtering of the animal, it is transmitted by body fluid and tissues of the animal if it is infected. So they should take care about they are wear and clothes, baron, and to protect themselves from the body fluids or tissues from the animal. Regarding the nosocomial infections or human to human, it is the IPC measures about the blood and body fluids. So the doctors, nurse, and so on, they should take care and should regarding the gloves, mask, and all these precautions should be taken when they take care of patient with CCHF. And all these devices, as a Ministry of Health and WHO country office, we advise and these by messages through the social media, Facebook, WhatsApp, and so on and so on. Over.
Thank you so much, Dr. Adnan, for explaining that a little further. There is another question again on, these measures. Is there a way to protect health workers during an epidemic, an outbreak really of CCHF? I think you've covered it. Is there anything else you'd like to specifically add?
You mean the health workers?
Yes.
Yeah.
Is there any specific recommendation for health workers for dealing with CCHF?
Is the awareness of the physicians to increase the awareness of the physicians regarding the CCHF, particularly people with certain signs and symptoms which may suggest this case it is an CCHF. So they should be aware about this case and take care of themselves, clothes, avoid pricking by syringe or by blood and so on. It is a matter of awareness of the physician, how to protect and how himself from this patient. I'm clear?
Yes, thank you.
Yeah, welcome.
Is there anything you'd like to add there, Kiori?
Now, yes, so as Dr. Adnan very nicely described, that the healthcare workers, they have to be first aware of the case definition, when to suspect CCHF patients. And also in some context, it's not actually in Iraq. I'm not going to address which country it was, but in some context, those cleaners, that usually cleaners, they are not our target, or like, they never receive those case definition. And then some cleaners, they were actually infected, and while the cleaning or like taking care of the patients, and then that's how they transmitted the created secondary infection and also the tertiary infection. So not only targeting doctors and nurses, but also anybody who is involved in the healthcare, they should be also trained, and they should be aware that when to suspect CCHF cases. And then once they suspect that, they have to be well protected with PPEs. That's all.
Thank you. So that's very important about what healthcare workers can do. So now as we approach the end of the webinar, one final question is, what is the one single successful strategy that has been used for managing CCHF? I will first ask Anai to respond to that, what she thinks, then Kiori and Dr. Adnan to add to that. So Anai, over to you.
Well, that probably be better to start with my colleagues that are in the field, but just my perspective on that, what has been successfully done, and of course there is Iraq, there is other countries, is for endemic setting to build up the ability to detect at sub-regional level, to set up some dedicated CCHF wards so that patient can be clinically cared for by trained healthcare worker to reduce the mortality rate in severe patients. This is what we are trying to focus very hard for the human health side, on top of course, preventive measure. But we can collectively, through the global health community, improve how we care for our patients if we are able to detect them on time, and if we have sufficiently trained health workforce, especially in endemic settings.
Thank you. Kiori, would you agree with her? What is your experience?
Totally, totally. And also, yes, yes, and also we have to continue our efforts on how we can operationalize One Health. Everybody likes the concept of One Health, but One Health is not only about the signing off the MOU or having the meeting. That how we can actually operationalize and make put that on the ground. That means how we can human and animal sectors, how we can operationalize and how we can work closely hand in hand on daily basis, and then how we can also support the veterinary sectors, because it's usually compared to human health sectors, the veterinary sectors are resource limited, and also how we can break through this conflict of interest that the wild animals not really presenting symptoms. So how we can operationalize One Health, integrating human and animal and the environmental health strategies. It's easy to say, but this will remain as a biggest challenge.
Yeah, in actual action is more difficult than well, having MOUs. That's the easy part. Dr. Adnan, from your wide experience in the field, what do you think is the one most important strategy that works?
Effective, efficient, with higher commitment, higher authorities commitment for One Health approach.
It has to be.
Yeah.
Thank you.
Okay.
There are, of course, many more questions. I'm just looking, and I think we've had about 80 questions, out of which half were answered. What we will do is get into the EPI-WIN team will work with technical experts here, and we will see if we can answer as many of your questions, perhaps as an FAQ, and we'll add those to maybe our Q&As, but we'll try and answer your questions as much as possible. But thank you so much for your interest in that. With this, we come to the end of today's EPI-WIN. As always, we will put the recording up on our website, and subject to agreement from our presenters, we will share the presentations as well. We welcome you to continue to be in touch with us. If you have any further questions, write to epiwin.who.int. It's in the chat box. And we hope to see you again next week. I'd like to thank our presenters, first of all. Thank you so much to Dr. Adnan, a very experienced public health expert from Iraq, who's given us the country experience, which can then, other countries can adapt and be learned from that. Thank you to Kiori for her interest and for explaining the situation in EMRO. Again, I think this will be very useful for other countries in EMRO. And Anai for the global overview. Thank you to Maria for her support as director. And also, I'd like to thank my colleague, Sophia Song, who has been the background managing the chat, and our colleagues from the WHO Collaborating Center in the University of New Mexico and Project ECHO, who supports us also. They've been monitoring the chat, helping in the background. You don't see them, but a lot of this organization is thanks to their support. So a huge thanks to that. And most of all, to all the participants, for your interest, for coming back, asking questions, asking interesting and relevant and thought-provoking questions, which helps us all. This is not a one-way thing. This is a two-way thing. We learn from you as well and what you want to know. So thank you for that. Our next EPI-WIN, we will have a special EPI-WIN next week on, it will be the launch of the first ever infodemic, let me just share my screen here, and so that you can see it. Our next will be a special EPI-WIN. It will be on Monday, not Wednesday. It'll be the launch of social listening in infodemic management for public health emergencies, guidance on ethical considerations. It's the first such ethical guidance for responsible social listening in public health emergencies. It's the first of its kind, and it will be launched by our Deputy Executive Director, Dr. Chikwe Ihek-Rizu, along with our Director, Nedret Emiroglu, and the Director for the Research and Training in Tropical Diseases, Dr. John Reeder. So please do join us. The QR code is there. You will get an invitation if you have subscribed to EPI-WIN very soon, and we look forward to seeing you. Once again, thank you all, and see you next Monday, and then again next Wednesday for our regular EPI-WIN. So we have 2 next week. Look forward to seeing you. Bye.
Right.